everyone, it is time to go over the hypothalamus and pituitary, the oversight now of the endocrine, especially the neuroendocrine system. All right, so this is just our introduction. We can see some structures on top, but we'll get a chance to look at them in more detail in just a little bit. All right, so the hypothalamus is a specialized portion of the brain, and again, this is something that I want you to think about as the homeostatic set point center. This is like your thermostat. This is what is going to set these really important limits. So we call it the hypothalamus because it sits below the thalamus. The hypothalamus has an interesting connection to the pituitary. So if we take a look over here, so here's the hypothalamus, and it extends down to the very base of the brain, and then there's a connecting stalk called the infundibulum. You can see that right there, the infundibulum. So the infundibulum is what connects the hypothalamus to the pituitary, which has two component parts. The first is going to be the adenohypophysis. You see that right there? And then the second one is going to be the neurohypophysis. So technically, we call the pituitary in general the hypophysis. And if you remember some terminology, neuro means that it contains some neurons, essentially, some central nervous system tissue, where adeno is referring to an organ or a gland. So sometimes we'll have things made in the hypothalamus that will then be delivered to the neurohypophysis, or we can have actual glandular activity in the adenohypophysis. So you've probably heard these referred to before as just anterior or front or posterior pituitary. So I definitely want you to remember those terms. However, I want you to understand that we're going to call them by their physiologic names now: adeno for gland, glandular tissue, and neuro for CNS tissue. And the infundibulum hangs down to allow the pituitary to sit in this bony pocket in the actual skull called the sella turcica, which means Turkish saddle. So that's a type of saddle that you would put on a horse, and it is Turkish, so they named it that. So when this little interaction occurs, I want you to remember that the infundibulum, this connecting stalk, is very thin. So if there's any kind of trauma to the brain in a type of injury, like an accident, some sort of CBT, so some brain trauma, the infundibulum can actually be severed because the pituitary doesn't have the ability to move along with the rest of the brain. It's physically stuck here inside of the skull. So we've got these two different areas of the pituitary which sit in this bony pocket called the sella turcica. So here's a nice slide. I'm going to make this picture a little bit bigger since I'm here anyways. All right, so if we take a look at these areas, remember adeno means gland. So here we have the adeno hypophysis. So these are actually glandular cells, so that means they have secretory capabilities. They can produce hormones, and then they can secrete them into this capillary plexus so that it can enter the bloodstream over here through the venule system. So that's a lot different than the posterior pituitary, which is made up of neural tissue. So we call it the neurohypophysis. So what we're looking at here, we've got two different nuclei and an associated nuclei up in the hypothalamus. There is one general locus of activity called the PVN, the paraventricular nuclei. And then we have the supraoptic nuclei, so above the optic areas. And you can see from this little brain slice here, we're just taking a close-up look at what's inside of the connection between the hypothalamus and the pituitary. So these cells, these neurons, their cell bodies send axons down through this infundibulum And then we have the end portions of the axons being the place where we would have vesicle release, in the same way that we have that in any other neuron. So the cell bodies are going to be in these nuclei, and then the long tracks of these axons is going to travel through the infundibulum. So together the track is called the hypothalamic hypophyseal tract. So it's a tract, a connection or a bundle of neurons from the hypothalamus to the neurohypophysis. So in the same way that neurons and any other cell that's secretory, they create whatever the secretory product is, it's going to be trafficked down the length of this neuron, and then those vesicles can be released whenever there's a stimuli. So this is really just a storage segment here in the posterior section of the pituitary. When there is vesicle docking and fusion, we can have the hormones that are stored here released through the blood supply into the greater physiology. There's only two things that are released from the posterior or neuro portion of the hypophysis or pituitary, and those two things are oxytocin and ADH, or antidiuretic hormone. And remember, we also will call that vasopressin in some cases. All right, so some other things. Again, I want you to know that these neurons will be creating the physical hormones that'll be trafficked down the length of their axons, and then they can be stored in the posterior pituitary. When there is connection, or there's a lack of physical connection between the hypothalamus and the adeno or anterior portion. So instead of just sending things down to the front part of the pituitary, what can happen is the production of hypothalamic hormones, and we call them releasing hormones, and those can traverse through the bloodstream so that they can be carried to the anterior secretory cells of the adenohypophysis. So this is trafficked through this portal system. We talk about portal systems a lot. It means like veins essentially that go in the counterintuitive direction. So there are products secreted through the portal system, and the hormones will travel through the bloodstream to bind to their receptor sites on the cells of the anterior pituitary. And then in response to those releasing hormones, these pituitary cells will spit out tropic hormones. There's a couple written down here. We'll go through all of them, but thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, growth hormone, and prolactin. Those are all created by the secretory cells themselves in response to releasing hormones binding to sites on the cell membrane. Okay, so as I mentioned before, this is everything written out that I had just told you going through the animations. It sits in the bony place called the sella turcica. Two anatomical divisions. One is neural in its structure, mainly storage, and those sites that are creating the physical hormones that are up in the hypothalamus are either the supraoptic nuclei, which makes ADH, so supraoptic makes antidiuretic hormone, which can then be trafficked and stored down here. And the PVN, the paraventricular nucleus, is associated with oxytocin production. So oxytocin comes down, same thing, through the axons and is released into the bloodstream. The adenohypophysis, so that's this area over here, the anterior portion, there's tons of secretory cells here, as we saw in those animations. They're mainly secretory. They respond to releasing hormones, and they're not greatly defined in their boundaries. So essentially, you're just going to have releasing hormones coming down here and then binding to whatever cells have receptors that would have an affinity for those releasing hormones. You'll also see this, instead of RH for releasing hormones, there's IH, and that stands for inhibiting hormones. So in this negative feedback loop, when levels of a hormone reach their desired homeostatic state, But we have, instead of releasing hormones coming down here to bind to spots on these cells, you'll have release inhibiting hormones coming down here and then binding to and blocking receptor sites on these cells so that we're not stimulating production of tropic hormones anymore. All right, so pituitary input is going to be associated mainly with things that will have some sort of interaction with the hormones being released. So it could be having to do with emotions, with things that influence sleep-wake, so light, smell, heat, energy, your calorie input, really anything that would be controlled by homeostatic mechanisms will kind of send a message to cause the production of these different hormones. The hormones will be synthesized, as we said in the last lecture, as pre-hormones, and we can track the release of these various products in a pulsatile type of nature. So some things are released once a day in a very predictable pattern. So as we said, also things like melatonin, they're released at night when it starts to get dark. So that's like a circadian rhythm. Just one day you would have a spike in release. Same thing with something like growth hormone that's released in a spike once a day. Some of these other hormones like follicle stimulating hormone or luteinizing hormones in female individuals, you will see the menstrual cycle. So that's anywhere from 28 to 35 days in what we would consider a normal amount of time for a menstrual cycle. So different things will spike at different times of the month. And then there's also circannual types of release, which circa is about or around. So circannual means around a year. So different products, they're increased during certain times of the year and they're decreased during other ones. But they all have their own pattern of release, which is generally pulsatile. It's just a difference in the time between those pulses. All right, so here's your first introduction to a negative feedback loop. This is just nothing filled in. It's just X's and organ or gland names right now. So the general structure I want you to start thinking about for these axis type of loops, it's going to begin with something hypothalamic. So hypothalamus makes something which is going to activate the anterior pituitary because there'll be the production of a substance. It'll bind to receptor sites on the pituitary cells. In response to that, the pituitary cells will release a tropic hormone, which will bind to receptors on a target gland, which will then spit out the desired hormone. So when there is a message to the body for any of these long loop things, so this could be a thyroid type of thing, this could be a cortisol type of loop, the hypothalamus has to start that by making a product which stimulates the pituitary, which stimulates the gland that makes that hormone to finally make it. And then you will see that the hormone itself is going to send messages to inhibit production once the homeostatic set level is reached. So this is the same thing with a little bit more detail. So here's the hypothalamus. And I said that the hypothalamus makes these releasing hormones that bind to cells in the pituitary. So here you have XRH, which just means releasing hormone X. It doesn't have a name, it's just an example right now. So releasing hormone X is made by the hypothalamus. Releasing hormone X binds to its receptor on the pituitary, the adeno portion. In response to that releasing hormone, we get our tropic hormone. So releasing hormone X stimulates the release of tropic hormone X, and then tropic hormone X will bind to receptor sites on the actual gland itself, and then we have hormone X released. Then hormone X will go up what we call the long loop to shut off production at the level of the hypothalamus by stimulating instead release of the inhibiting hormone. So adequate levels of hormone X will cause inhibiting hormone X to be released, and that will inhibit pituitary production of any tropic hormone. There's also a short loop that involves tropic hormone X when there's a nice strong level of the tropic hormone that can shut off production at the level of the hypothalamus because the brain senses that it's made enough of that hormone. And then there's also an ultra short loop, so really high levels or adequate levels of releasing hormone X can shut off production of the hypothalamus, making more of that releasing hormone because it's just made a big bunch of it. All right, so hopefully that makes sense. Hypothalamus makes releasing hormones. Those releasing hormones make the pituitary release tropic hormones, and the tropic hormones cause the glandular release of the systemic hormone. So fun. So we can take a look at the ones associated with the pituitary. And honestly, for the rest of these lectures that go all the way up to reproductive, this is one of the most important slides that you're going to see. You can sleep with this. If you print it out, I would put it underneath your pillow and dream about it and look at it every day if you want to really learn the products of the system. It is all written out for you, and it's a pretty good visualization of what all these parts are making and releasing. So again, we've got the hypothalamus, and as we looked at before, there are neurons here in the PVN and the supraoptic. So they begin here in the hypothalamus, extend all the way down to the posterior pituitary or the neurohypophysis, where we can store these two products, oxytocin and antidiuretic hormone. Oxytocin, as we'll see in a little bit, is most important for uterine contractions during delivery and mammary gland contraction during nursing. Antidiuretic hormone, you might know that diuretics, like the pills themselves, they cause water loss or increased urination, which is called diuresis. So antidiuretic means anti-water loss hormone. So when you're in a state of dehydration, there's antidiuretic hormone release so that any extra water that would be typically added to the urine is retained. So it causes water retention. And the way that it does that is by causing these little pores to be inserted into the nephron collecting duct, and we'll take a little look at that. But antidiuretic means your body is in a state of dehydration, typically, in a normal physiologic state, and the body wants to preserve any water that it has, and it signals to the kidney not to excrete any extra water. So there's nothing in between these because remember, these are connected. We could just draw, this could be a neuron, just going from the hypothalamus, coming right to the posterior pituitary. And those products are just released out into the bloodstream to cause their general activity. All right, where there is going to have to be a hormone in between is the anterior pituitary or adenohypophysis and the hypothalamus. In order to signal to these glandular cells that we need something, the hypothalamus needs to make a releasing hormone. All right, so again, those releasing hormones, they're going to bind to receptors on the surface of these glandular cells and turn them on. And in response to being turned on, the pituitary cells will make tropic hormones, something that causes increased growth or activity. If we have had enough of that hormone, we're back to normal homeostatic levels of the hormone in the bloodstream. The release inhibiting hormones can be made by the hypothalamus to, instead of bind to and stimulate these pituitary cells, they'll bind to and block these pituitary cells so that there's no more production of tropic hormones. All right, but if there was a releasing hormone and now we have activity and we've got a tropic hormone that needs to be made, we've got a couple of different products that just go right out into the bloodstream. That's why they're in red. And they have general activity. So they work in a variety of places and they're going to cause some widespread activity. So the first one is growth hormone, which is named very well. It causes growth primarily of long bones. And Eventually, in humans, there's a time when the bones seal, so the epiphyseal physes, the skeletal physes seal, and that happens around the end of puberty. Once those plates seal, the growth plates seal, the long bones cannot grow any longer. However, they can grow thicker, so we're going to see that in a little bit. And then there is also a high amount of protein deposition that comes from growth hormone action. So we have protein deposition in the form of increased muscular growth, and then before the skeletal physes seal and they're open, skeletal physes, we can have long bone growth in response to growth hormone release. Okay, prolactin means prolactation. It physically stimulates the cells in the breast tissue that make milk to make milk. Prolactin has to work along with oxytocin. So prolactin will cause the cells to make their milk, but the milk will stay there unless oxytocin causes the milk to be ejected. So oxytocin's milk ejection, prolactin is milk creation. And then finally, we have melanocyte-stimulating hormone. Melanin, as you know, is made by different cells in the skin, which creates pigment. So you'll see in some of these endocrine disorders, there'll be abnormalities with coloring of the skin. So there'll be blotches of either hyperpigmentation or hypopigmentation. And I want you to remember that that finding is tied to melanocyte-stimulating hormone being made by the anterior pituitary. So those three hormones go into the bloodstream. They don't have a second organ that they work on. The ones down here in red are tropic hormones, but they are going to have an additional gland that they work on. So the first one is thyroid stimulating hormone. It's got a great name. It tells you exactly what it does. Thyroid stimulating hormone, or TSH for short, binds to cells on the surface of the thyroid and stimulate production of T3 and T4. Then we have ACTH, adrenocorticotropic hormone. So the adrenal cortex has cells there. And the adrenal cortex, there's 3 different levels to it, and they each make their own product. The one most sensitive to ACTH production is cortisol. Cortisol is released in a lot of different situations, including sympathetic stimulation. ACTH stimulates cells of the adrenal cortex to make cortisol. So we have our thyroid loop, we've got we call this our HPA axis, hypothalamic pituitary adrenal, usually thought of as the stress pathway. And finally, there's the HPG axis, hypothalamic pituitary gonadal. And that involves 2 different hormones named for what they do in women, which makes it a little bit confusing, but I don't want you to be too confused. But follicles are the kind of the seeds that grow into eggs. They're the early forms of egg cells in the ovary. So follicle stimulating hormone causes follicles to start maturing. And luteinizing hormone is the other gonadotropin. To luteinize means to yellow. And the corpus luteum is the product left over, as we'll see. When there's ovulation, the egg bursts out of the ovary, it leaves behind some dead tissue. It looks dead, but it's actually physiologically active. And it's called the corpus luteum. And LH is going to be involved then with the production of the corpus luteum. So LH is going to be, in females, the hormone that drives ovulation. So follicle stimulating causes the eggs to start to, mature and go down their line to become active follicles. And then luteinizing hormone drives ovulation. In males, there are no follicles with eggs, but there are sperm. So FSH is going to be associated with spermatogenesis, the production of mature spermatids, and luteinizing hormone is associated with testosterone production. So they have different activity, obviously, in males and females, but they have the same name. So don't get confused. Just when we get there, I want you to remember what they do in each body. Woo, there you go. That's all of the pituitary gland hormones and their interaction with the hypothalamus. So if you take a good look at this slide, this is really everything, or all of the hormones that you're going to have to know. They're all right here. Okay, just finishing up very quickly with the different hormones that are made by the pituitary or stored in the pituitary, starting with the neurohypophysis. So we've got our two different nuclei, the paraventricular and the supraoptic nuclei. They're up in the hypothalamus. One of them, the PVN, is making oxytocin. The supraoptic is responsible for making vasopressin, or ADH. Those products are trafficked down the length of the axon, stored at the end of the axon, and then released into the bloodstream when it's necessary. And as I mentioned, ADH, antidiuretic hormone, is for water conservation during dehydrated states. Oxytocin is important for milk ejection and then delivery and contraction. Okay, what you're looking at here is a graph with urine osmolality on the y-axis, so how many solutes there are relative to water. And then you've got plasma vasopressin, or ADH. Same thing, same, different name, same thing. Old school name is fine. So you'll see that the more vasopressin that's produced, the more solute is in the urine. So think about it this way: when there's ADH release, the person is still going to urinate. It's not that they're not going to pee at all, but when they do produce urine, it's not going to be a watery, clear urine. It's going to be a very concentrated yellow, dark urine. And that would be expected because we want to conserve any water. So it won't be a watery urine, it will be a highly concentrated urine. So you'll see ADH again when there are dehydrated states and the body is trying to conserve water. Okay, oxytocin, as we mentioned, this is important in delivery, and it's also important in breastfeeding. Both of those processes are positive feedback, and they stop when the stimulus is removed, either the fetus, which we talked through before in the first lecture, or the suckling at the level of the nipple. So oxytocin works along with prolactin. So when there's prolactin production, the cells in the breast tissue produce milk. But that milk will stay there in the area, in the milk cells essentially, until there's contraction in the smooth muscle surrounding those cells. And that is possible. If the milk doesn't leave, it gets impacted there and it causes breast infections, inflammations called mastitis. So it's really important that oxytocin be stimulated to cause what's called the milk letdown or the milk ejection response. So taking a look at the picture here, the prolactin was made already by the pituitary, so there's milk continually being produced from the extracellular fluid and other things in the female's body. So the milk is made by the cells in the breast, and when there is a suckling stimuli at the level of the nipple, then that will stimulate, see, the suckling or sucking stimulus will stimulate the cells in the brain to make oxytocin. The oxytocin is going to be most important for causing contraction of the smooth muscles around the mammotrophic cells making milk, and then the milk will be moved into the duct, because this is a duct pathway. Milk doesn't travel through the bloodstream. It'll travel into the milk duct and then into the mouth of the child or baby or whatever, pump, whatever there is. And then when the suckling stops, then that's what stops this positive feedback loop. So it says here that the cycle can be interrupted by stress. What happens there is there's too much cortisol production and you can interrupt this pathway. You can imagine that one of the first kinds of stressors there is with nursing is sleep deprivation, which is really off homeostatically, so that can be something that can interrupt oxytocin production. Because of the way the the delivery positive feedback loop works, when the infant or the fetus is moving down and pressing on the cervix, that causes vaginal distension, which causes more oxytocin release to move down the fetus. That is why some psychologists believe that some women have more of an emotional connection to sexually intimate partners than a male might, because of the natural delivery pathway where vaginal distension in delivery causes oxytocin release, which is also associated with things like bonding and love. So it's an interesting theory. We can talk about that later if you want, but that is a natural physiologic process during delivery to encourage fetal evacuation. So oxytocin is milk ejection, okay? Here is what these cells look like. So here's adipocytes or fat cells. Breast tissue is highly fatty, as you got to see in gross anatomy. Both males and females, it's fatty tissue. And then there are these myoepithelial cells, muscle epithelium, and here's these little acinar cells, essentially. So we saw acini in the pancreas, and we'll see them again in the lungs. So these myoepithelial cells, so see how this is all muscle. So all of these cells are associated with milk production, and then this muscle here, when oxytocin is around, it'll contract. So it will cause all the milk that's produced to be forced into this duct, so then it can be released out of that. Oxytocin binds to plasma receptors. You get calcium increase in target cells, so the cells depolarize and then they can contract. So as we mentioned, oxytocin is also important for uterine contraction and delivery. You may have heard of a drug called Pitocin. So Pitocin, in hospitals, women will be put on a Pitocin drip sometimes. And what Pitocin is, if you look closely, it says oxytocin injection. Pitocin is synthetic oxytocin. So when there's low doses of oxytocin, either with breastfeeding, so it is common that in breastfeeding, when there's a suckling response, there'll also be cramping in the uterus because it's a widespread physiologic action. Low doses of it, there's rhythmic contractions. High doses, really sustained contractions, because that means in normal physiologic delivery, the head is pressing really hard on the cervix. There's a lot of vaginal distension. So the more oxytocin that is released, the stronger and longer the uterus is going to contract to evacuate the fetus. So if you give a really high dose through a drip, that's what's used to induce a delivery in women that are either taking too long to deliver or have just scheduled an induction anyway. So Pitocin, it speeds up labor, very long, strong contractions because it's a very high dose. Whew, okay, man, I'm getting tired of talking, but I'm almost done, okay? So the anterior pituitary, as we mentioned, it is spread apart into these different, poorly organized zones that are going to involve cells that make these different tropic drugs. We're going to go through each of these specific products when we get to that organ or gland chapter. So we'll talk about thyroid hormones in the thyroid chapter. There's just a few, as you saw on that table, that don't go to specific glands. They just go out to the bloodstream, so we'll go over those ones to finish up the lecture. The first one we've already mentioned, it's prolactin. So prolactin, we know, works along with oxytocin. Oxytocin causes milk ejection. Prolactin, when it's made by the secretory cells in the anterior pituitary, goes out into the bloodstream, stimulates milk gland cells so that it makes milk. So prolactin's milk production, oxytocin is milk ejection. All right, here is the full feedback loop for prolactin, because it has to work along with some oxytocin stuff too. So I mentioned before, like stress, lack of sleep, they can have alterations to hypothalamic activity and prolactin production. But generally you need some estrogen to be created, which is normal during pregnancy, and then during the period after pregnancy, lots of estrogen is created. The more estrogen, the more activity of prolactin. And then the more suckling, meaning the more times a woman nurses, then there's more activity, there's more stimulation to the cells there to make prolactin. More prolactin equals more milk. So that is interesting. That is why newborns feed so many times a day. And women are asked to just put it into their schedule to plan on nursing like every 2 hours. Because as the infants are doing most of their growing, you want really high prolactin levels so that there's an adequate level of milk production. And that's also when they're doing, the huge bulk of their growth. So when somebody is not nursing, they are given, if they're in the hospital, they can be given an antagonist for prolactin so that they don't start this letdown effect. If the woman chooses to nurse, the prolactin levels remain very high and elevated for 8 to 12 weeks to allow for that rapid growth period. And then they return to just kind of a baseline level of activity until there's no more nursing, and then there won't be any more activity. There is something called relactation, where somebody can spontaneously relactate when they hold a baby. If they were to adopt a baby, they can relactate because of high prolactin production in some cases. There's also something called, I already said relactation, but if somebody did adopt a baby and they wanted to nurse them, they can be given injections of prolactin to stimulate a lactation process in themselves. Okay, so that's your prolactin. The other thing that prolactin is important with, as pregnancy is something that occurs, the breast tissue goes really up in size. So here's an immature breast. So there's mainly just circulating estrogen and progesterone. A mature non-pregnant breast, the alveoli that make the milk and collect the milk, they're small. The ducts are pretty small. And once a woman gets pregnant, the breast size goes up by about 2 to 3 cups almost immediately. And that has a lot to do with really high levels of estrogen and progesterone that are present during pregnancy. Then after delivery, the kind of the hormonal sequela of delivery causes a huge amount of hyperplasia of these alveolar milk cells. So there's a huge amount of proliferation and branching of the breast ducts. So this is what a lactating breast would look like versus a pregnant breast. So the breast size is going to go very, very high to accommodate the growth of all of these different ducts. Once there is absolutely no more nursing, a couple of months later, there will be a physical apoptotic process here of these mammotrophic cells, and they will start to die off. The skin elasticity has a lot to determine, or is really important in determining what's going to happen to the shape of the breast afterward, but there's going to be a huge size change and then a regression and a loss of all of these different ducts, whereas just the fatty tissue would remain. Okay, other things. Final thing that doesn't really go anywhere else, but just the bloodstream. We've already talked about growth hormone. Soma means body, so we call this the tropic hormone, somatotropin. Again, main effect, very early on, long bone growth until there's sealing of the plates at the end of the long bones. It's also anabolic in its activity. It encourages protein deposition, and it's very important for growth hormone to be present for normal growth and development. Here is your feedback loop for growth hormone. Hypothalamus, when we need growth hormone, it produces growth hormone, releasing hormone, which binds to cells in the anterior pituitary and stimulates them to make growth hormone. When growth hormone is adequate, it will feed back up to the hypothalamus, telling the hypothalamus it has enough, doesn't need any more, and if everything is working properly, the hypothalamus will make growth hormone release inhibiting hormone, which will bind to and antagonize or block receptor sites on the anterior pituitary cells and shut off production of growth hormone. Straightforward, right? Yes. Very good. So governed by growth hormone releasing hormone, regulated metabolically. So if glucose goes down, free fatty acid goes down, growth hormone goes up. The more somebody fasts, so you've probably heard of intermittent fasting and things of those nature. When you spend more time in caloric debt, the amount of growth hormone release there is goes up. So that has an anabolic activity, which can have some gains associated with it. Growth hormone is also stimulated in the presence of ghrelin, which we talked about in the GI chapter. Your ghrelin causes your stomach to growl and you to feel hungry. So it stimulates the appetite and also, growth hormone release. Kids hate to sleep. My kids never sleep. I haven't slept in, almost 6 years or 7 years now. How nice. Oh, good. So it's important that you try to force them to sleep even if they don't want to. And the reason why is growth hormone is released really one cyclical spike a day. It's a circadian type of pattern, and it's about 1 to 2 hours after the onset of deep sleep. Meaning if that child, or even you, it doesn't matter, everybody has growth hormone release, but it's most important to kids who actually need to have long bone growth. They go to bed at 9, about 11 o'clock, there's going to be a huge spike in growth hormone release, which is going to be over already at 2 in the morning. So sleep is really important so that you have adequate growth hormone expression. We talk about these more in patho, but just to put a little bit of pathophysiology here, growth hormone deficiency, this is also called pituitary dwarfism. And pituitary dwarfism is just a lack or an insufficient amount of growth hormone production. This is a young girl. She's 6 years old, and her initial photo when she saw her pediatric endocrinologist is here. I want you to notice that her long bones are quite short. So for a 6-year-old, she has a pretty small stature. The only thing really affected are long bones. You can have normal growth of the other types of bones. This is 15 months of growth hormone replacement therapy. We just call that hormone replacement therapy. And I want you to notice that the biggest difference here, so pituitary dwarfism is just not enough growth hormone. Everything is in proportion to every other part of the body. It's just short. So after replacement, you'll see that these long bones, they've started to grow. And you'll also see some of this anabolic activity with muscle development. So that's pituitary dwarfism, and there's also pituitary giantism. Almost always in endocrinology, whenever there is a mass of like a benign growth of an endocrine gland, that means that that gland is going to make way more of that endocrine hormone than it typically would. So if there is like an adenoma, means a gland or an organ growth or tumor, it would just, if there's one in the anterior pituitary of the cells that make growth hormone, there'll be a huge amount of growth hormone that's created. So this is an individual in this picture. He's about 19 years old. His name is Ming Ming, and he had a adenoma on the anterior pituitary. So if the plates are open, then the long bones can continue to grow. So giantism is increased long bone growth and an open skeletal physis system. If you don't remove the tumor, the pituitary becomes compressed, and then you have no pituitary hormone production, which means it has to be replaced synthetically every day. That's called pan hypopituitarism. We'll learn about that again more in patho, but I just wanted to show you what this looks like when it's too much release versus inadequate release. But remember, this giantism, you have to have open skeletal physes. If the physes are closed, that means the bones can get thicker but not longer. And that's a disease called acromegaly. Anytime you see megaly, that means enlargement in. So acromegaly. That is hypersecretion of growth hormone, but the plates are closed. In this case, you'll see that the fingers get very big, especially at the ends. They become like almost flattened at the ends, called like spoon-shaped fingers. The forehead becomes very prominent, and you'll also see that the forehead will continue to grow and the features of the face will become much thicker. And again, this is just because the physes are closed when growth hormone is hypersecreted. Again, almost 90% of the time this is caused by a benign growth on the area in the anterior pituitary associated with growth hormone production. Once that growth is removed, then the problem is resolved. However, you guys also know that bone changes are not something that are very readily reversible. So this is something that is a lasting type of change. And that is it. So I said a lot of these things. All right. So you should be able to answer this. Overproduction of somatotropin in an individual with open skeletal physes will result in osteogenesis imperfecta, acromegaly, giantism, or achondroplasia. So you take a look at that. We'll talk about what the answer is the next time I see you, and have a great evening.